Hi, my name is Nina Sanford, and I am a GI radiation oncologist at UT Southwestern in Dallas, Texas, where I am the chief of GI radiation. I have been here for since 2018, so for about 4.5 years. I treat cancers throughout the GI tract, but have a particular interest in colorectal cancer, particularly in young patients, as even during the time I've been here, I've been seeing more and more young patients diagnosed with colorectal cancer. I have several research interests, but they all sort of center upon improving the therapeutic ratio of radiation therapy and personalizing and individualizing radiation, acknowledging that sort of a one-size-fits-all treatment strategy isn't really the best way to do radiation. My goal is to individualize radiation so that patients can have a better quality of life after treatment, however they choose to define that, while obviously also maximizing their chance of cure. In that regard, I'm involved in several clinical trials seeking to adapt and individualize radiation therapy. I work closely with translational researchers with the goal of identifying biomarkers of response to radiation. It is great to be a part of Town, and I look forward to learning from you all. So thank you so much for having me as a part of the talk tonight. Thank you. Okay, and I'm going to be talking about two presentations that were oral abstracts at GI ASCO in the colorectal session, and also not from GI ASCO, but a recent paper that came out with updated trial results. So the first study that I wanted to talk about, let me just move my camera, is the NRG GI002 study, a phase 2 clinical trial platform using TNT, Total Neoadjuvant Therapy, in locally advanced rectal cancer. So just to give some background, I'm well aware the group is probably very familiar with this, but traditionally for locally advanced rectal cancer, radiation was given first, followed by surgery and then adjuvant chemotherapy. And the idea behind total neoadjuvant therapy is to do surgery last. So what are the potential benefits of this? Early control of micrometastatic disease, better chemotherapy adherence when giving it before surgery, downstaging of the tumor, and then earlier colostomy removal reversal that can be done just a month or so after surgery. There are potential downsides, one of them being potential overtreatment, because you're relying, again, on initial staging without the pathologic staging. That being said, patients on this trial were mandated to be higher risk, which I'll talk about in the next slide. So what was this trial? So again, these are quote unquote high-risk patients. They had to have low-lying tumors. They had to be bulky and or requiring an APR. And they were essentially randomized to different TNT strategies, all starting with chemotherapy, followed by long course chemoradiation, followed by surgery. The trial was a platform trial, essentially allowing the investigators to assess the addition of additional drugs to be given with chemoradiation. So the first one they assessed was veliparib, a PARP inhibitor, and then the second one was pembrolizumab, which is a PD-L1 blockade. And I just wanted to quickly talk about the design of the study, specifically the primary endpoint. So unlike other studies where the primary endpoint is a clinical outcome, they actually looked at something called the NAR score, which is a validated short-term surrogate endpoint for DFS and OS, disease-free survival and overall survival. The thought behind this is that those endpoints take longer to read out. So having a shorter term endpoint could provide earlier data regarding the efficacy of these strategies. And there's actually a formula for that written here, but essentially it relies on the clinical T stage and then the pathologic T stage and nodal stage. Secondary endpoints of the study were shown here, but pathologic complete response, clinical complete response, overall survival, disease-free survival, toxicity, and then rates of the additional features shown here. So what did the study find? So in this slide, the top box is the results from the arm that included veliparib, and the bottom is the arm that included pembrolizumab. Essentially, nothing was statistically significant with regards to the PCR rates, also the NAR score, the clinical complete response. They did find that pembrolizumab improved a 3-year overall survival from 87% to 95%. In listening to the presentation, the presenter, Dr. George, mentioned doing some additional studies to really figure out why this was the case, given that the other endpoints were not improved. So I think take-home points from the study. This was really the first cooperative study of the total neoadjuvant therapy strategy. So I think a take-home is that TNT is safe and feasible in locally advanced rectal cancer. Neither of the drugs in combination with radiation improved short-term outcomes. I think more investigation is needed to really figure out what was driving the OS benefit. But there are still a lot of ongoing questions regarding TNT. I think the first one is patient selection. Should all T3, T4 node positive patients undergo this strategy? Sequencing, should we do radiation or chemotherapy first? This trial included chemotherapy first, which was, I think, what was initially done before the OPERA study. And then radiation schedule, which we'll touch upon a little bit more later, either short course versus long course chemoradiation. This study used long course. The value of surrogate endpoints, and then also not addressed in this study, but will be in future studies, triplet or doublet chemotherapy, and also combinations, systemic combinations with radiation. So the second study I want to talk about is the OPERA trial, not to be confused with the OPERA trial. This is a study of a randomized trial of earlier stage rectal cancer. So these had to be T2 to T3B, N0 to N1, and they had to be located within 10 centimeters of the anal verge. So the control arm here was external beam chemo radiation to 54 gray with radiosensitizing chemotherapy. And then the experimental arm was that plus a brachytherapy boost, which I'll talk about in the next slide. Of note, these patients did not get any FOLFOX or any additional chemotherapy. It was just either chemoradiation or chemoradiation with brachytherapy. So just a little bit of background, what is brachytherapy? It is essentially internal radiation therapy, can be in the form of seeds, for example, radiation seeds for prostate cancer, a catheter or plaque-containing radiation that's placed either directly in or around the tumor. Because it's placed in the patient or in the tumor, it permits the delivery of very high doses of radiation, sometimes up to 100 gray or more. However, also because of that, it's really only suitable for small targets. So what did they do on the study? They used an applicator and essentially placed it over the tumor. And you can see sort of a very idealized tumor in the figure on the left, where they're placing the brachytherapy applicator over. Each patient got 3 treatments, and you can see on the right, they just gave an example of how the tumor really responded very nicely, even by the 3rd treatment. I should just emphasize that, again, a very high dose can be given with brachytherapy. So on this trial, patients got 90 gray brachytherapy, 30 gray per fraction, which equates to a biologic effective dose of 360 gray. So this is really a very high dose of radiation to the tumor. So what were their findings? They found that at 2 years, the clinical complete response rate was 92% with a brachy boost and the arm receiving a brachy boost. And for patients with smaller tumors, less than 3 centimeters, actually the organ preservation rate was 97%. So very high, as you can see in the graph here. So I think take-home points from this trial are that ablative radiation can be curative for select patients with early stage rectal cancer. As I mentioned before, these patients never received FOLFOX chemotherapy. They only got CAPE or 5-FU with radiation. As promising as these results look, I think there are caveats. One, just logistically, many centers do not have capability to do this brachytherapy. Not all patients qualify for rectal brachytherapy. And then toxicity data is needed. We know from other studies in rectal and also in esophagus cancer that brachytherapy to intraluminal structures can have high rates of both acute and late toxicity. So I think we definitely need to flesh that out a little bit more before making this strategy more widely used. A lot of ongoing questions regarding organ preservation, which I know Josh will touch upon more, but I think one thing we talk about a lot in our tumor board is, should organ preservation be the goal for all patients? Obviously, it's the patient who should decide, but I think that is something that we think about with locally advanced rectal cancer cases. What is the optimal radiation regimen? What is the optimal timing for response assessment? And then how frequently and what modalities should be used for surveillance? Okay, so just 2 more slides. This just came out on January 20th, so just about 10 days ago. And this was a 5-year follow-up of the Rapido study. So just to give some background, this was a study, a phase 3 randomized control trial of more than 900 patients. And it was essentially a trial assessing short course total neoadjuvant therapy. So patients on the study were randomized to an experimental arm to receive short course radiation, chemotherapy followed by surgery, or the historic standard of long course chemoradiation, surgery, and adjuvant chemotherapy. Patients were required to be high risk. With the features here, they had to be either T4, have EMVI, have their tumor touching the mesorectal fascia, or having lateral nodes. And the primary endpoint of the study was a composite endpoint of 3-year disease-related treatment failure, defined as having a distant met, a new tumor, a treatment-related death, or local regional failure. So the initial results of the study were presented at 3 years, and they show that the experimental arm had better disease-related treatment failure. And that was driven by a lower rate of distant mets, and that continued to be shown at 5 years, is 27.8 versus 34%. The new finding in the 5-year update, however, was that the short course radiation arm had a higher rate of local regional recurrence, 10.2 versus 6.1%, so 4% difference, and this was statistically significant. On the plot on the left, just to sort of explain what's going on, the bars that are going to the left under EXP are the experimental arm. The bars going to the right on the side STD are the standard arm. And initially, right off the bat, you can see that there are a lot more bars to the left, demonstrating that there were more recurrences in the experimental group. Most of the bars are blue, meaning most of the recurrences were after an R0 resection. The authors described some imbalances in the arms in terms of their treatment. One is slight differences in radiation techniques, and then also more mesorectum breach at time of surgery with a short course arm. But, I think one has to think about the fact that the short course radiation also had a lower radiation dose, which potentially likely, I think, was probably a risk factor for these delayed recurrences, despite having actually a higher rate of pathologic complete response in the experimental arm. So that is all I have. Happy to take questions.
Thank you very much, Dr. Sanford. One question that I got from people in Coltontown was that Dr. Gina Brown's talk, she talked about EMVI and, tumor deposits. So how about those, then she was talking about how those were, more important markers to see whether there'd be recurrence, right? Do you want to comment something about that?
Sure. So I think, first of all, those are sort of newer markers too. I think in the, we weren't really seeing EMVI without rectal MRIs, which are done a lot more now. Tumor deposits, we definitely see less commonly than positive nodes. So I think when we see that, we do think that is a risk factor for local recurrence and EMVI local and systemic recurrence. So I think I agree with that. I don't know if I agree that they are more important than TNN staging. One thing I did want to bring up, though, kind of separate, was that I I think something that is very important in determining the likelihood of a complete response is really just the tumor bulk, like the tumor size, the number of CCs, which isn't really captured in the T and N staging because it's really the tumor depth of invasion. So, all T4 tumors are not the same. Some are T4 just by a little bit, some are like occupying the entire rectum. So I think that in my practice is something I've definitely seen to be a predictor of likelihood of response. Obviously, the biology can be different between tumors that look the same, but I think that's something that should be probably explored more. At least that's what I'm seeing.
Okay. So this was Annie's question. So I think the debate part of the role of EMVI, etc., like as you said, it's only after people have started using rectal MRI where they could see EMVI, that's when people have started talking about it, right?
That makes sense.
Yeah. Okay.
Can I ask Nina a question real quick?
Mm-hmm.
I was just curious, Nina, with this data from the Rapido trial, does this dissuade you from using short course? Because obviously there are good reasons to use short course as well.
So, our center has been a huge pioneer of SBRT, hypofractionated radiation therapy, short course radiation. I think with the Oprah study, we kind of swung back towards long course chemoradiation because that was really the biggest study for organ preservation. I think there still is a role for short course. Again, the Rapido study was more high risk tumors. So I think if you have one that doesn't fulfill those characteristics, not super ugly, I think short course is reasonable. And then also I think if the goal is not organ preservation or there is such really very low likelihood of organ preservation based on all the things we talked about, then I think in the pre-op setting for most rectal cancers, there is still equipoise between short and long course based on the earlier randomized trials. So I think there's still a role.
Okay, Dr. Sanford, I have this question for you. I think at GI ASCO, they had many posters where they were looking at chemoradiation plus drug X, right? And they were trying to see if by adding something on top, can you cause shrinkage? Do you want to make some comments about, what's the trend? Where is the field going?
Yeah, so the thought behind that, and a lot of those are immunotherapy drugs. So, the response rate for non-MSI high rectal cancers for immunotherapy is close to 0%. So the thought is that if we combine that drug with radiation, can we improve the systemic response? So I think there's a lot of excitement. We had a randomized study of short course and immunotherapy. But I think so far the results have not been super promising. So I'm definitely excited to see more that's coming out. But for example, in the NRG GI002 study of the PARP inhibitor and Pembro, both of those were negative, and that was a big study. So I think so far nothing slam dunk yet.